Okay, hi. My name is Tracy Brown. I'm part of the Livewell Southwest team, and I work in a dementia assessment unit. So the quality improvement project that we've embarked on is, so not falls, but it's reducing aggression and violence within a dementia assessment unit. So our project, so I suppose just to give you a background on EdgeCom unit, we're an acute mental health unit. We admit patients that have a diagnosis of a moderate to severe dementia, and they suffer from distressing presentations that pose challenges to their caregivers. These presentations often include high levels of anxiety, aggression, violence towards others, and it's named BPSDs, Behavior and Psychological Symptoms of Dementia. By the time the patients are admitted to the unit, they usually have reached the end stage of their dementia, and they lack the mental capacity to understand any of their care needs, interventions, and treatments. They lack insight into their disabilities, and they've lost the ability to process, understand, and even communicate any of their care needs. Our aim with participating in the Quality Improvement Initiative is to use evidence-based information to reduce the levels of incidence of aggression at the point of care. And we aim to reduce the distress in the least amount of time by understanding the individual and what is causing their distress, to use the least restrictive interventions to manage and to treat their distress. A bit of a background, I suppose. Our unit sees a large number of incidents of aggression and violence towards staff members and other patients. It's regularly highlighted by our organisation, and we do feel supported. And we're obviously morally and duty-bound to protect our staff and our patients and the general public in general. Our organisation has working policies that we abide to as well. And having a look once working on this project, the NICE guidelines also suggest firstly, exploring the least restrictive options. Are there any environmental causes? Do they have any physical illnesses? And are they in the appropriate care provision? It goes on, NICE guidelines, to suggest medications and interventions that are suitable to the treatment of older persons. So our driver diagram, our aim is to reduce incidence of challenging and distressing presentations, the BPSDs, by November 2018 by 20%. We started this project in March, so I attended my first conference here in March 2016. So the primary drivers were environmental factors, monitoring the ward environment using the measles graphs to identify hotspots within the unit, to encourage patient engagement in therapeutic activities and being very time-specific with those. The strategic personalized monitoring was risk identification and monitoring to begin on admission, development of a monitoring tool to specifically measure challenging presentations, such as aggression and agitation towards others, and the promotion of team working and focus group working. For proactive ward-based research and ward culture, it was about the monitoring of incidents related to challenging presentations and evidence-based learning with care planning for the individuals. Our PDSA testing ramps, we identified risks handed over care and monitoring from admission, risk awareness and management, capturing incidents on a graph, and developing a plan of care using a monitoring tool. We were measuring and displaying where incidents are occurring in the unit by means of measles charts, staff involvement and focus groups, and also managing the environments, monitoring the effectiveness of the treatments. We aim to improve outcomes for patients at the point of care, to reduce the levels of distressing presentations in the unit, to reduce the incidence of injury to staff and patients through aggression and violence, to highlight times of the day when staffing levels could be enhanced, to promote communication and focus groups to early identify triggers, to help reduce the length of stay in hospitals, involving carers by sharing the data with them so they can help us identify the reasons behind challenging presentations. For instance, oh, I know why they're doing that. It's usually the time they go for a walk, or he was a postman, so he would always get up at 5 in the morning. Correctly identifying times of the day when distraction techniques, calming music therapy can be used. Targeting times when it would be appropriate to administer medication if required. It would also give us an accurate visual representation of patterns of behavior, which is easy to present at ward rounds and discussions with family. And we're looking at areas in the unit where distressing presentations are occurring, our measles charts. This is an example of our measles chart. So the red stars would be incidents of aggression and violence in the unit, and the blue stars are, incidentally, we're managing the falls as well. On the left-hand corner of the measles chart is our lounge dining area, and on the right-hand side from your side, and on the left side are the bedrooms. So you can see when everyone's washed and dressed, everyone usually goes to the dining and the lounge area, so it is a place where everyone gets together most of the day and spends most of their day there. And the red stars in the bedroom area would be aggression and violence at the point of care for washing and dressing. So with this information, and it's predictable, so every month we do a measles graph and we're seeing the same information. So by doing this, we ensure that patients are represented and they supported by having extra staff in the day areas. So there's always 1 or 2 staff members in the day areas. In the afternoons especially, we're seeing the aggression and violence. And we're making sure that we've got the laptops out and we're working out in the day area to support our patients. Personal care in the mornings, quite often it's just really supporting the patients, and also perhaps that's the time when we need to administer the medications early to prevent these aggressive behaviors. The LifeQI system has encouraged us to think about how we can improve and measure the provision of care in the unit. We found that with a slight change in our existing monitoring paperwork, we were able to gather enough information to transfer on a graph to provide a visual of the day and a week in the life of our patients. We were able to share this data with the MDT in order to plan their care. It identified trends in times of the day when patients were more likely to fall. It clearly identified sleep patterns, which helps us ensuring individuals are supported. And we were able to accurately manage and treat chronic pain by identifying times when patients became more agitated as they were unable to communicate the pain to us. We also shared this data with residential and nursing homes when planning future placements to see if they're able to manage their care and presentations. We have less patients going out of area to PQ units as we're able to manage and treat more challenging patients in the unit in a more controlled and structured way. This is an example of our we called it a personal activity monitoring observations. So we monitor all of our patients every hour, most of our patients every 15 minutes as well if they're needing more intense observations. So what we've done is we've changed the form just slightly, but we haven't added, for any nurse, you don't want any extra paperwork added. So we've used the present monitoring charts. We've added a little column. You'll see the challenging presentations. So it's just to give an idea of what presentations have become a risk and what we would like to measure. And then instead of writing just whether the patient is on the ward or off the ward, we've actually given a little code. Can you just let us know what presentation are they calm, are they asleep, are they agitated, or are they aggressive, to try and see if, for each individual patient, if we can see if there's a pattern. And this is what came out. So from that monitoring chart, we put it onto a graph. So example 1. We've got JP. Her risks are agitation and falls. So from the graph that we see there, she's calm and relaxed most of the day, around about 3 o'clock, and this we have from Monday to Friday, so we can see a full pattern of her behaviors. So it looks like towards the evening, round about 3 o'clock, becomes quite agitated. And then round about bedtime, it seems that she gets a little agitated as well. So at night time, gets up a few times at night. So what we've tried in the first instance is some distraction and music therapy in the afternoons, target the time at around about 2:30 to try and see if we can distract her from the agitation and keep her busy. And as we go along, if that doesn't work, it's strategically administering medications at the right time to reduce that anxiety. For her falls, we can see she does wake up a few times at night time. And it's no guessing because it is on a graph and it's there for everyone to see, and we do it every single night. Bed alarms are in situ to manage her nights. If she does happen to get up at night time, we're there. We've got the bed alarm and it'll alert nurses that she may be in need of assistance. In example 2, we've got EK, who came in with high levels of agitation and aggression. They didn't seem to be able to manage her, also very high risk of falling. So it became soon very clear that by looking at our graphs, we were giving her the usual paracetamol every 4 hours, but you can see by the graph, every 4 hours, there was a breakthrough of agitation, so it was quite clear her pain wasn't managed. So first thing in the morning, we would give her analgesia before giving her any personal care, and that managed the agitation in the morning, and then managed her pain a little bit better. So by the end of her stay, we saw a nice, calm, and less agitated lady who was sleeping really well. You could see her night patterns. The third example is a gentleman who has high levels of aggression and agitation. With him, he'd lost mental capacity, did not understand any personal care. So that does become a problem. As much as you can explain to someone about personal care and what it is you're doing, they're still agitated and aggressive. So with him, the only thing we could do was try to administer medications before personal care. So we've got the 7 and 8 o'clock in the morning personal care that became a problem for him and for everyone else, and also at night time. So those are 2 times of the day we could do something about that. He was doubly incontinent, so during the rest of the day, it would just be planned interventions and try to manage it as quickly and easily as possible for him. This is an example of a gentleman who came in very, very distressed, agitated for most of the day and the night periods. And so we've got a before treatment and an after treatment. And if you see the after treatment, it's a huge relief for relatives to see. You've got a gentleman who came in really, really unwell, and by the time he left, he was able to go and be discharged into a nursing home and quite easily managed. Daily focus groups that we have. So we try to do this especially before multidisciplinary team meetings, and then also on a daily, whether it's a handover, just discussing each patient to see if there's anything we can possibly do according to the patterns that we have discovered. Activities in the unit, so strategically having various activities and to try and manage patients at certain times of the day. Memory boxes, so it's involving relatives, getting them to bring in photographs and writing at the back of the photographs who are in the photographs, and just to allow us to be able to discuss personal things for the individual. And if they write at the back, we know exactly what it is we're talking about to them. So it's a brilliant distraction technique, and it's something special that they can go and leave hospital with as well. Challenges during the process, so resistance from staff members to change. Why do we have to do this? We've always done it perfectly before. It's about consistency and staff engagement, so constant encouragement. The one thing we did have a problem with is when you are monitoring behaviors or presentations, can you please monitor it the whole hour from 7 until 8 o'clock, and not just what you see at the time, so we can get an accurate representation of the presentation of the individual. and then just fine-tuning, so training staff and getting them to see the big picture. Okay, thank you.